So tonight we'll be talking about FASH, the focused assessment sonography of HIV and TB patients. So FASH, not to be confused with the FAST, point of care ultrasound that we more typically use in our ED, in our trauma patients. So today it's the FASH exam, not the FAST exam. And we'll discuss how point of care ultrasound, so the FASH, can be used to find signs and diagnose HIV-associated TB. So looking at the epidemiology, so the HIV currently has about 13% prevalence, roughly 8 million people, KZN being the highest province of disease. And we also know that Mycobacterium tuberculosis is still the single most infectious organism and is still largely responsible for morbidity and mortality. And so today we'll look at if we look at the middle of the Venn diagram, so the HIV co-infected population, this is about 270,000 people annually, with children alone amounting to about 7% with just TB infection, and then the HIV TB co-infection in kids amounting to about 2.7% of the middle of this Venn diagram. So the percentage in the era of heart is definitely decreasing, but in the HIV dual infection, morbidity and severe disease is still a big contributing factor in the kids under the age of 5. So we know that when you're co-infected with HIV, your risk of MTB disease progression and reactivation increases to 5 to 15% annually. And then you also have an increased risk of relapse and reinfection. So we know that this population pose diagnostic challenges. They often present differently. They often are smear sputum negative due to the poor subacillary nature of TB. And then they can even be TB culture negative. And then radiologically, they often have atypical x-rays, and that further leads to diagnostic delays. And then also this co-infected population, 20 to 25% will also have extrapulmonary and disseminated disease. So that further, increases the diagnostic challenges and the delayed initiation of TB treatment. And thus the emphasis on an efficient diagnostic tool to address these diagnostic challenges has led to the development of the FASH exam. So the FASH exam is a targeted point of care ultrasound designed to be used in a high prevalence emergency setting, designed to assess specific findings related to HIV and TB and correlate these findings to the likelihood of TB to make the diagnostic decision and initiation of treatment faster. So it was developed in 2010 by an infectious disease specialist in KZN, and it actually modeled the FAST exam and how short protocols were successfully established in the ED in a trauma setting, and took a similar approach and developed the FASH exam, but looking for common manifestations of extrapulmonary TB. So what was the method? So they did a prospective study, which looked at about 414 adults, so to note, not kids, but adults only. And they looked at the WHO classic 4 symptoms. And so the patients that were HIV positive and with the WHO classic 4 symptoms, and they did FASH exams on these patients. And then this was correlated to those that were confirmed to have either a positive gene expert or TB culture. And then the selection criteria was then based on the relative ease to recognize these findings, and then the diagnostic and therapeutic decisions that these findings led to. So then they developed the FASH basic and then the FASH plus. So the FASH basic, you ask yourself 3 questions. So is there pathological effusions present? So is there a pleural effusion? Is there a pericardial effusion? And is there ascites? And then in the appropriate clinical setting, this is highly suggestive of extrapulmonary TB. And then the FASH plus, it's a 6-probe exam, and you're looking for additional findings. So you're looking for enlarged lymph nodes and then liver lesions and microsplenic abscesses in the spleen. These findings is a little bit more difficult to recognize, but we need to try to visualize as these are, the FASH plus is more superior. So what the FASH basics looked at is that any one of the effusions yields a 73% sensitivity with only a 54% specificity, meaning it was not that good in identifying those who did not have TB as negative. The secondary outcomes of the FASH plus, the 6-Pro, looked at, in addition, and found that intra-abdominal lymphadenopathy was then the most predictive of extrapulmonary TB, with ascites and pericardial effusion being the second and third. Similarly, it looked at positive findings on the plus and looked at if you have more than one finding, your specificity then increased to 91, and then if you have 3 findings to 93%. And then more so, it also looked at individuals with advanced HIV, so those with CD4 counts of less than 100, so severely immune compromised, and the sensitivity was 82% in the FASH plus exam. So this diagnostic tool can be rapidly taught, requires very little ultrasound experience, and the fact that in our high prevalence setting, these pathological findings are often present in our HIV/TB co-infected in-hospital patients. There's really only benefits to doing this, using this diagnostic tool. The examination only takes a few minutes, and there is still an advantage to doing a more formal or comprehensive ultrasound. Abdomen, in a more formal, you could look for nephropathy and cardiomyopathies and cardiomegalies, but these were not included as part of the routine FASH because you obviously need a bit more skill. So how do we do the FASH exam? We want our patient in supine. We want to use a curved or linear probe. We want to have gel, and then we want to look at the 6 positions in the diagram, and we want to ask ourselves, is there pericardial effusion? Is there pleural TB? Is there ascites, lymph or abdominal lymphadenopathy? Are there liver or splenic lesions? And then just to note that this was the best image I could find, but the probe position for 3 and 5, it's obviously more in the flanks and higher up and not as low down as the image. So the FASH protocol it looks at the 5 P's. So you want to look pericardially and periaortically, and then peridiaphragmatically on both the right and the left, and then you want to look at the pelvis. Okay, so for the first position, you're looking for a pericardial effusion. We should be considering a pericardial effusion in every short of breath HIV patient coming in with chest pain or features or signs of progressive heart failure, tachy, hypertension. We want to always consider and exclude tamponade as a life-threatening cause of chest pain, and we always want to consider looking for Beck's triad. And then any chest x-ray really that has cardiomegaly in an HIV positive patient, we should definitely be putting a probe and looking to see, is there a pericardial effusion? So the probe position, we want to look in the subxiphoid region and the epigastric angle, and we want to sort of scoop under the ribs and get cranially, and pathologically we will see an anechoic or black rim which separates the visceral and the parietal pericardia. We can also then see fibrin stranding, which is basically because of high protein particle and purulent exudative effusion. So it will be echoic streaks basically within the pericardial effusion. Just see if I can show that. So pericardiocentesis is not recommended in a hemodynamically stable patient, but in an unstable patient, we're thinking of tamponade, and we can definitely consider doing a pericardiocentesis as life-saving. And then the pericardial fluid itself, it's often straw-colored. However, if we're thinking bacterial superinfection, it can be more putrid. And if it's more blood-stained, we can think of things like Kaposi's and malignancy. So when we're looking for abdominal lymphadenopathy, in that same subsurface view, we're just going to move a little bit down and cordially to look at the periaortic area. And then pathologically, we're looking for lymph nodes of 1.5 to 2 centimeter or larger in an HIV infected individual. And as we can see on the left, we have what's considered normal. And then on the right, we can see that the hypoechoics, or the dark structures around the aorta. And remember, this is the highest correlation, so the highest predictive value for TB or extrapulmonary TB. So furthermore, we can also monitor the size of these nodes, and that's not more for us in the ED, but potentially if they had sono in the wards, you could monitor the size, and that could tell you if it's increasing in size, or together with a worsening clinical picture, it could mean iris or non-compliance, or if it's persistent, it could mean we've got the wrong diagnosis, such as lymphoma or Kaposi's or MDR. Okay, and then when we move to looking for position 2, peridiaphragmatic, we're going to look for pleural effusions. So we're going to then ask the patient to then move their arms behind their head, and we're going to look at the right mid-axillary line, and we're going to use the probe in the longitudinal axis, and we basically going to, normal is when we're seeing the diaphragm and the apical parts of the liver. That's when there's no effusion, and we should see a curtain-like movement up and down with the respiratory cycle. And then pathologically is when we're seeing the basically fluid in that cosophrenic angle. Let's have a look. So here we can definitely appreciate that the diaphragm should be a hyperechoic, and then there's this loss, and you'd basically just see lots of fluid. And again, you can use ultrasound guidance to do a thoracocentesis. And remember, in the HIV setting, to just also consider pneumonia or CCF as other differentials other than TB. Okay, and then we going to look for ascites and liver lesions. So just in the flank, we're going to look for the edge of the liver and the right kidney, and between the two organs, we should be seeing, because of the capsule, we should be seeing a hypoechoic, so the white line. But if we're seeing this echo-free fluid between, we then know that there's ascites. And then we're also going to look through and scan the liver and actually look for liver lesions themselves. So we want to try and, in the view, get the inferior pole of the liver as well as the kidney in the same view. And again, we can see hypo or, sorry, this was going on here. The liver lesions could appear as hypo or hyperechoic. And then usually the hypoechoic lesions are more fungal and amoebic abscesses, and usually PCP is more hyperechoic. And then just to note, you can also see or comment on hepatomegaly. However, this is not specific at all for TB, and as HIV positive patients often have hepatomegaly. And then for position 4, we're going to look peridiaphragmatic on the left. So we're just going to mirror what we did on the number 2. So we're going to look in that same mid-axillary, and we're going to look between the spleen and the left diaphragm, and pathologically is now seeing fluid above the spleen. I hope this one is projecting okay. All right, and then moving on to 5. So now we're going to look for ascites and splenic lesions. So the same as mirroring what we did on the right, we now do it on the left. So we're going to look between the spleen and the kidney, and then also look throughout the spleen for the splenic lesions. So pathological is when free fluid collects in the splenorenal pouch and visible as an anechoic black fluid. Looking for the splenic lesions, you might notice hypo, so dark, or hypoechoic again. And then anything more than 0.5 centimeters is diagnostic and should make you think about disseminated TB. Okay, and then for position 6, so this position we know very well, we're looking for ascites. So we place the transducer on the symphysis pubis, in the longitudinal, and then also in the transverse, and then we're looking deeper than the pelvis, and what we might see is, or what we should see is echo-free. What we will see in ascites is that we will see echo-free, so we'll see black structures behind the bladder of a male, and then behind the uterus, so in the pouch of Douglas, we'll see free fluid representing ascites. And then here on this image, we can just appreciate that on the left, we can see that there is a normal contour of a bladder, and then on the right, we've lost that contour. And let's just play the video. So on the right, we can see, I mean, this is definitely ascites. You can appreciate that there's bowel floating in an anechoic space, loss of the bladder's contour. And then when we move video along, we can just see that in a female patient, we'll see the uterus, and then we can see around the uterus, we can still visualize the bladder, but we can appreciate that there's fluid in the pouch of Douglas. And remembering that fluid often will collect here as a fluid-dependent area, often first. Okay, so just as a summary, the FASH basic versus the FASH plus. So the FASH basic, we'll only be looking for the 3 effusions. So is there a pericardial effusion? Are there pleural effusions? And is there ascites? Any one of these individual characteristics in an HIV positive patient has the sensitivity of 73%. But even better is to do the 6-probe FASH plus assessment. So asking yourself, is there abdominal lymphadenopathy? Are there splenic lesions? Are there liver lesions? Remembering that lymphadenopathy has the highest predictive value for extrapulmonary TB, especially in our HIV population. The limitations of the FASH exam, this needs to be done in a high prevalence setting. Though this is a limitation, it's not really a limitation for us. This protocol was obviously only developed for adults. The clinician operator dependency obviously needs to be remembered, and this does not give us a definitive diagnosis, but rather helps us to determine the likelihood of TB in our setting, and then to help assist in the faster initiation of treatment. And then in the era of ultrasound as a bedside tool, it's relatively easy, it's quick, it's often very helpful in the diagnosis, especially when patients are smear negative or culture negative. It often will lead to sooner identification and initiation of treatment. And that's it, guys. Happy scanning, and any questions?